Said, "Oh, it's not magic, it's math." Okay, great. And I was like, "Did you think it was magic?" And he's like, "I didn't know, but thank you for showing me it's math." And so if I had a magic wand, I'd still want to get back to math. But I would say, that the transparency rules would have dire consequences for those that don't. I don't want more laws. We have enough laws. But there are laws in place to say, like, the hospitals have to publish all of their pricing. Well, guess what? The penalty for not doing it was $300 a day. You're talking about hospitals. I'm situated here between Duke and UNC.
$300 a day.
$300 is like closing a window in the CFO's office.
But thanks again for being on today, man. I really appreciate it.
Yeah, thanks, Nate. I appreciate it.
So I was hoping to just start with kind of the 3-minute sequence of how you just got to where you are now from where you started.
Yeah, that's the big question, right? I came in the side door, I would say, of healthcare and health insurance, two totally different things. I was working with alternative risk. As my then 14-year-old daughter said, "What do I tell my friends you do?" Because she couldn't think of anything more boring. I couldn't think of anything more exciting. But we were building the first captives in North Carolina. I'm calling in from Chapel Hill. And that was back in 2013. It was, I say this in jest, but it might be true. It was the last thing that our legislature voted unanimously upon. So passed the captive laws, and then what? And so I went and knocked on the door of the commissioner and was stunned to see that I was the only one that approached her. She became a good friend. And we went around the state and other states training professionals, law firms, accountants, CEOs, CFOs, all sorts of different professionals on alternative risk, meaning how can you self-fund certain things that make sense and pay less in premium out of your company coffers. And I met some surgeons along the way, and we built a captive for them because they were clearly above average. We had all the data, 5 years of readmissions, complications, infections, success, everything. And these were clearly top 1% in the country surgeons, and they were paying the same rates as the hacks, as they called them. And I was like, first of all, we can help you on your procedural risk and your insurance, but why aren't more people seeing you? Like, why aren't my friends going to you when? And so I became enamored with the complexity of healthcare and how to steer patients to better facilities, better physicians to get better outcomes. And the big surprise was you pay a fraction of the cost if you do that. And so I was blown away when we did the math. And so here I am a couple of years later, toiling away, trying to scale this thing. So
yeah, I mean, it's crazy to me, and I just made a post about this on LinkedIn today about how you and I, we know, and thousands and tens of thousands of people, if not the entire country, we know that the system as a whole is more or less broken. I mean, yeah, it hasn't like imploded, but
right.
for all intents and purposes, I mean, you've got incentives that are just misaligned everywhere. And so it's amazing that like the solutions are actually out there, yet they don't, like, at a large scale, to your point, they're like not really getting implemented. So with that, what do you think are like, what do you think are the primary barriers to that actually happening, to widespread implementation of getting people into surgeons who are lower cost and actually produce better outcomes?
So there's a lot of obstacles, right? This, I can't remember which law it is, but Newton's most powerful law is inertia. I just remember that body at rest tends to stay at rest, and that's how we can think about the broker community. We can think about the decision makers, the fiduciaries at health plans. They're at rest. They want the easy button for the most part. And until they get jolted by a 25% increase or two 10, 15% increases back to back, they're liable. They're going to stay where they are, and so we're in a very reactionary business where people get a renewal and then act. There's not a lot of strategic thinkers out there who say, "Hey, I only got a 5% increase, but you know what? I can see the future, and I want to go ahead and plan ahead here and move to a better plan." We don't get that very frequently. Occasionally, but not frequently. And so you have this mindset of, kind of, we call it the merry-go-round. The view's always the same. You just change horses every year or two. And you see a lot of plans that are, we've been with Blue for 2 years, and then United, and then Cigna, and then Aetna. And we call it the Buca merry-go-round for Blue, United, Cigna, Aetna. And so uh, nothing much really changes. Their margins are about the same. Their networks are 99% overlays. They have this. Their vice presidents change seats every 2-3 years. So that's the status quo. And when it was like the frog in boiling water, they could just turn up the heat every year, and it was just enough to keep 98% of the people in the pot. They did it. Well, now they're all raising the temperature too much, and so you're starting to see not 1 or 2%, but 5, 10% of plans, which is a lot. These are tens of thousands of plans. Say, I've had enough. I'm jumping out of the pot, or keep the analogy, I'm getting off the merry-go-round. I'm going to ride my horse, over here, free range, and go, put something together. That's the first problem. So the first problem is inertia. The second problem is they've done a really good job psychologically to keep people in the status quo. The third problem, and the one that we're working on, is how do you when you unbundle these plans and remove to the best vendors the different components, the drugs, the risk, the medical, the steerage, the communications and reporting. When you move those out of the big tower and into the best components, the best players in each of those fields, you have to stitch them all together. It has to appear seamless to the buyer and the member. And that's been the biggest challenge for us, Nate, as an industry, is how do you take advantage of all those best practices and still keep the experience seamless?
Yeah, that's something that I've been having a lot of these conversations lately, probably, dozens a day. And the thing that I hear consistently from brokers, consultants, advisors, CFOs is, please just make it easy.
Right.
Please just make the implementation easy, the usability easy, the user experience seamless. Like, please just work on that. Um, and a company.
You're not the only one. We hear
Yeah.
that. Yeah, that's the constant refrain, right?
Yeah.
Is I want
Like,
the 20% savings for our plan, and I want the, probably 20% savings for the employee too, with all the zero deductibles.
sure.
I want all that. I want the better care, lower cost, more control. We say the 3 Cs that the DNA of these proactive plans have in common.
Yeah.
But I don't want a line out my door Monday morning if I'm HR, and I don't want emails on Saturday if I'm the CFO or CEO saying what happened,
Yeah.
and so when you unbundle anything, the most famous case being cable and all the parts of cable, when we used to just pay 100 and then 150 and then 200 and ridiculous amounts every month. And you got 400 channels, 380 of which you didn't want, but you were forced to pay for. The unbundling happened. It was very messy at first. People could, you see what Netflix and Amazon and ESPN and Hulu and now people are stacking various modular pieces together again, and some are happy and some aren't. But it's not a seamless experience. There still was some friction there, right? You didn't get what you wanted at the time you wanted it for the price you wanted. And so healthcare has some similarities. Obviously, it's much more important and complex than the next, Disney movie, but at least to most of us. But
Don't
I'd
tell
say
my daughter
this,
that.
there are great things happening on the platform or productization, to use a business school, bastardized term, of proactive plans on which will rest the best point solutions, which will then have a common reporting system back to the decision makers and to the employees and the navigators, so that it's not toggling between 25 different vendors and hoping to get a report on their performance, vendor performance, and accountability. That's happening.
And so like with what you're doing with Hero, like that is that's a platform, and hopefully, the platform to win them all, I suppose.
Well, and we didn't start, like all the best laid plans, right? I'm, totally honest with you. When I started, I thought Hero would be accentuating what I was experienced with, which was direct contracting and risk. And I said, wow, it doesn't take a math genius to figure out paying $25,000 for a hip replacement with the best doctor in the state in a clean facility is a lot better than paying $75,000 with a new doctor in a dirty hospital. Even I knew that. And so, okay, well, we had direct contracts for $25,000 all in for the best doctors. Voila. Well, they're going to beat my door down. No, 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 no. No, you needed a nurse navigator, we found out belatedly. I didn't have engagement in our first business plan. I didn't even include it. I don't think you could find it. We thought that if you paid less, then stop loss insurance would decrement you more. You'd get lower premiums, and we would save twice. We would save the company on lower insurance, and we would save the employee. It'd be zero if they chose wisely, and the plans would save. What a win-win-win. But all the best contracts just sit there gathering dust unless and until you have exceptional employee engagement. And so we learned the hard way that you can't just have a webinar, you can't just have a Zoom or send out a mailing. It has to be a cadence of communication across the entire yearly calendar. It has to be concise, important, timely. Yeah, it has to come in multi forms, like a newsletter, an invite to an in-person meeting, a webinar, recorded. We send refrigerator magnets to everyone's home. We do all sorts of different, any way we can reach the people. We do a monthly thematic newsletter. So June is Skin Cancer Awareness Month. May was Mental Health Awareness Month. You have tips and tricks from your nurse and your pharmacist to continually reemphasize, hey, you've got a nurse and a pharmacist on your plan. You didn't have that before. How about calling them or texting them or emailing them and getting the most out of your benefits? And they don't do it day one. No one sits there and goes, thank God I have a nurse. I can't wait to get in touch with her, except for one or two people. Mostly they're like, wait a minute, don't we have something on our plan like 8 months later? And oh yeah, I pay zero if I call the nurse, and I can get an MRI instead of paying $3,000 out of pocket for the same MRI. And the water cooler talk starts to go around, and then people start saying, this is a great plan. That takes time. And so we learned the hard way that it's all about employee engagement, or your contracts aren't worth anything. Really.
Yeah, no matter how well you build a plan, yeah, if nobody uses it, then what's the point? And I learned this the hard way. Yeah, absolutely. And I learned this the hard way too, just being a physical therapist working with patients, right? Like, when do people come in? When it's the worst.
Right.
They don't. Yeah. They would have benefited if they came in before it was the worst. In fact, they would have done a lot better. But
right. I had
like
frozen shoulder. I found out the hard way. I didn't even know what it was. I was Googling frozen shoulder, calling my doctor friends. What is this? I can't even put on my blazer to go out to this, award dinner thing.
Oh, there's a business idea. Build a one-armed blazer for frozen shoulder.
I was stunned. I was like, how did I miss the meeting on this? But you're right. I never thought about physical therapy until it was too late. And then all of a sudden it was medically necessary. Right.
Right. Yeah. And it's, and I find this now that I've been across several different industries, or just different parts of the healthcare industry. At the end of the day, there are some truisms. Nobody is going to make a move until the pain is too high. Even the people with the best of intentions, like even myself who understands the value of exercise, and
Right.
I want to be, that fit grandpa at 100 years old
Right.
skiing down a mountain. Even myself, who has all the knowledge and all the tools, and I would say pretty high levels of determination, there are even weeks where I struggle to get into the gym or go out and work out, right?
Sure.
Just for a
You're
variety of
human.
reasons. I'm
Yeah.
human, right? And so, and I have all the information, all of it.
Yeah.
I
Right.
do not have
Right.
incomplete
Which is
information
frightening to
in
the
the
rest of us who
which
get
right,
by.
right. So it's so
Yeah.
I can understand the challenge from just even the individual perspective, and then from the employer perspective of not really wanting to necessarily make a change until the pain is so high.
Right.
But I don't know. I even though we struggle with that, I think there's still a better way. Like maybe instead of it getting to like a 10 out of 10 pain, we can start making changes when it's like a 6 out of 10, right?
Yeah. It's multifaceted, right? Some people are calling us because CAA guidance, trickled out, and then finally seeing that as a fiduciary on the plan, they're now personally, liable for their plan being spending money solely for the benefit of the employees and passing the prudent test. So maybe that $5,000 MRI with a buca is no longer going to be considered prudent when there's a $500 MRI across the street.
So tell me what
Maybe.
CAA guidance is.
So
I'm
the
not familiar with that.
Consolidated Appropriations Act, which I believe was the largest or second largest bill ever passed, it's an omnibus bill. It had thousands upon thousands of pages. Tucked into that bill were some nuggets around changing health plans that impacted ERISA and DOL guidance, and trickles down, of course, to all these plans we're talking about. Some of them, say that now there's guidance around what's fiduciary responsibility. And ERISA passed in 1974 and put the onus on plans, businesses that were collecting money out of your paycheck to have two big buckets of responsibility. One was financial. If they're taking money out of your paycheck to, fund an HR or a 401k or retirement plans, they have very strict rules around, they can't hire Uncle Bubba to invest in his favorite stock, right? Or his new restaurant scheme or something. It's highly penalized and organized. Well, in healthcare, it was just it was more loose, right? It was like you choose the best health plan, you're supposed to spend your money wisely, but there was no one really got hurt. There was no one remembers people getting sued over having a bad health plan. There was occasionally, but it wasn't mass tort stuff like there was on the fiduciary financial side. That's all changing now because health plans have become so much more expensive. There's more attention from attorneys and the government and hearings and everything on Capitol Hill, and so they said we need to have more guidance around this. Health plan fiduciaries are now personally liable, and in most plans, not including churches and some other exceptions, the stakeholder, the board of directors can be personally liable. So all of a sudden, that board of directors beach house is available to an attorney who can prove that your plan is not spending money wisely, prudently, and that's scary because these attorneys can go after. They're not starting with the small plans; they're going after the Fortune 500, right? But eventually, everyone's under the same law, so they could. It's just a matter of we don't want to scare people. It's not nothing to be worried about. If you're doing things right, you're doing things right. But here's the three things it distills down to. You have to own your data. You can't be, so no more Blue Cross or United or Cigna saying, hey, it's our data. We'll give you what we want. Or we'll sell your data, which they do. I even heard of people renting the data. I don't know how that happened. But you have to own your data. You have to understand your data. It can't be through a fire hose like all these raw claim files. It has to be understandable. And the third bit of guidance is you have to take action. So if you see through your data that you now have from your plan that you have people overpaying for drugs, you can't just say, well, the data's mine now, and I see that they're way overpaying for drugs. You have to do something about it.
Hmm.
So it's not defined as to, there's no precedent on the court system to say here are the criteria for overpaying for drugs or surgeries or MRI. There's none of that yet. This is
How
just
how
new.
is that determined, the overpayment of drugs? Because I st I still see insane
Yeah.
charges for very basic drugs from people on regular, like fully insured plans all the
Oh,
time. So
sure.
what
Oh, yeah.
so what's
There's
the deal
it's
with that?
Yeah, it's so there is no precedent, and the guidance is just guidance. There's no criteria in there to say this is an overpayment, like it's X percent of this or 10, 10 times what the cost of the making the drug. There's nothing, and so you can only compare it to the rest of the market, right? And say, well, if you're buying a drug for $100 and someone else is buying it for $800, that's probably, it seems egregious on its face, and that could get somebody in trouble. If you're buying a drug for $100 and my plan's buying it for 105, I don't think that's going to raise it. And there's no case there. No attorney's going to stand up to that. But I think what you're going to find is the shenanigans, will use good old Irish terms for it, that happen with the rebate. That I call it the heroin in the healthcare system. People get hooked on these rebates and they don't make wise decisions. They see that, hey, we're buying this drug for $500. It's generic. It's made in the same factory on the same day, same exact drug. One gets a branded label, one's a generic. They buy the branded for $500. The generic's $100, but they're getting $100 rebate. And meanwhile, their employees are going bankrupt or struggling financially for overpaying for this drug. But the CFO is seeing a check every quarter for 10, 20, 100,000, whatever it is, and saying, no, 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 look, I'm getting a check. I'm hooked. I've got to get my rebates. It's really it
That's
it is
that's insanity to, I mean,
it's a
because
drug.
because
It's a
you
drug.
know that the branded companies, they know this. This is
Oh
why they're
yeah.
doing it.
Oh, they
This, I
wouldn't do it
mean,
any
they
other way. It's for
I
marketing.
mean, it's very clear. They know the marketing game that they're playing.
Yes.
Um, and I get it, but it's like you would think that the CFOs would also recognize that, and maybe they do recognize that,
I think
but
they're
they just have
starting
to
to.
prove that they. I don't know. I'm not
They're,
sure why.
they're starting to. We had a great conversation with a super sharp CFO last week, and after the Validation Institute conference, I drove straight down to Greensboro and met with a CFO of I guess about 2,000 employee company. And I won't name them, but they're really sharp. They're so interested, and they're in a BUCA plan. And they said, "What do we do? What's the lowest hanging fruit?" I think was the part of it. What do we do first? And
Yeah.
I said, "Well, the first thing you're going to see returns on would be the PBM or the drugs. What do we do?" I said, "Well, number one, we get your formulary and we remove the wasteful drugs." And they're like, "Well, why would we have wasteful drugs on there?" I'm like, those are the best rebates. So what
Uh,
is a wasteful drug? And it's not my definition. We subscribe to the Johns Hopkins. They publish kindly a wasteful drug list. Uh, Academics, medical clinicians put out the wasteful drug list. I think the criteria is that the drug in question has a formulary equivalent or a generic available for 90% less than the branded drug. So that's a good place to start, right? Like
yeah.
who's going to defend this drug versus the poster child for all this, of course, it's been beaten to death in our conferences, but might be good for your audience, is Duexis. I encourage everybody when I meet an HR professional, just check your formulary for Duexis. And they say, I will, but what is that? Well, it's a brilliant marketing scheme. Um, this drug company took headache medicine like ibuprofen and mixed it with an antacid, Pepis AC, took the two pills and put them together. So instead of a $5 medicine, it's $1,000 medicine. So it's on formularies. It's on many, many or most formularies, and they give a huge kickback. to the plans, and it's a terrible ripoff. It's literally just those two medicines in one pill, and so you get drugs like that on your off of your formulary, and you're immediately cutting waste, right? And there's hundreds of these drugs, at least 100. So that's step one. Step two would be looking at all your specialty drugs, which specialty drugs just means drugs above a certain cost. Some people say $1,500 a month, some say $2,000 a month. It's an arbitrary thing. I thought when I first started, specialty drugs had an asterisk, like a clinician said that's a specialty drug, very different than a branded drug. And finally, I was like, wait a minute, why is that a branded drug and that's specialty? They're like, well, that's $1,500 a month, that's $1,300. And I was like, okay, so that's the criteria. So specialty drugs need to be, that's a category that needs to be addressed aggressively, in my opinion, with prescription assistance, manufacturer's assistance programs. If you're so inclined, you can do personal importation. Many aren't, many are. There's FQHCs, federally qualified health centers, that have drugs that hospitals have 340B programs. A lot of clinics do. You don't have to pay full rack retail for specialty drugs. But all the BUCAs do, Blue, United, Cigna, Aetna, each have their own PBM in their stack, in their bundled stack. So the Blues collectively own Prime Therapeutics. Famously CVS bought Aetna instead of the other way around, but Express Scripts and Cigna are tied up, and Optum and United Healthcare. And so those BUCAs control combined about 90% of all the scripts in America. So 90% of the drugs dispensed in America go through the BUCA system with huge profitability. It's the highest margin business of any of those guys. In a portfolio of high margin businesses, this is the best.
Yeah. So I've been wanting to ask this question to somebody who could actually answer it, because on YouTube, I have not been able to find the answer. What does a PBM actually do? Like,
next to nothing.
Are they necessary?
They're not necessary. They're only necessary because of the proliferation of drugs and the dispensing and the fact that we want to use a card and swipe it at Walgreens or Walmart or Costco or wherever we're going to get drugs. That system is the what the PBMs can control. And so they don't actually make drugs. They don't actually store drugs, ship drugs, sell drugs. They're the intermediary. It's somebody said it's like The Sopranos could learn a lot from the PBM business. And now what are they doing, Nate? They've been under scrutiny. The head of the lobbying imagine this, they have hundreds of millions for lobbyists.
Oh, of course.
No surprise. They're actually saying that they're not subject to CAA, that they're not subject to all these transparency rules, that's actually the employer, and the employer does not need to hire them, and therefore and shift responsibility for transparency. Meanwhile, they're starting these buying groups in Switzerland. Now, why would they do that? Well, when the servers move over to Switzerland, very private privacy laws and everything else, they feel like Congress won't get in their hair as much, and so it's just shocking. But like I said in the beginning, this is the opportunity, because if you have such an egregious money-sucking operation reaching into your employees' pockets and taking out hundreds, if not thousands, reaching into your coffers, giving you a little kickback called a rebate to keep you quiet, and you go in and show people the delta is often $1,000 per employee per year in savings, same exact drugs, just paying for it a different way.
Talk about the easy button.
Yeah, and you have, this is it adds up very quickly. If you do that, they're so bad that it's an opportunity for the transparent folks to come in, and there's a huge delta there between these types of plans.
So tell me and this will be helpful for any, CFO or benefits manager or consultant who doesn't know this, but for a fully insured company or a self-funded company,
Yeah.
can they both go about changing the formulary, or can you not
No,
do that with a fully insured plan?
no. You think about it this way: on the, if you gave me a marker, we'd be here all day. But think about it like on a whiteboard. If you start on the far left, you have fully insured, and then you move just an inch to the right. The next phase would be level funded.
Mm-hmm.
In fully insured, the Buca Blue United Signet, and it controls everything. It's everything in the tower. Think about risk, drugs, medical, records, steerage, reporting, compliance, communication. Everything's in the tower. You can't improve on any of it. You can't change any of it. Then you move to level funded, and they say, well, if we save money, let's say we save $100,000 this year below expected, we'll split it with you 50-50. And you're like, wow, that's great. We got nothing during our good years when we were fully insured. Now, if we have a good year, we'll split it. We'll get 50. We do all the work, but the Buca is going to give us 50% back. No, 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 no. It's not cash. It's Chuck E. Cheese coins. You can only spend them with the Buca. You can only buy the pizza at the Buca. So you get a rate increase too. You're like, wait a minute, we saved you 100 grand. Actually, we did all the work. We're only getting 50 grand back, and it's not even cash. And our rates went up by 50 grand. What gives? Well, that's the Bucas, right? That's the Sopranos. And so, that's level funded. Everyone likes it in theory. No one likes it in practice. And then the next one over would be ASO, and that's administrative services. So when you stay in the Buca world, but you go to self-funded Buca, you're still renting their network. You're doing their drug program. You're doing their records. They're doing the stop loss, but they're showing you all the data. So if you perform well, you get to keep the money in this arrangement. If you perform poorly, you got to pay extra, but it's all transparent. But you have no options. You can't choose better doctors. You can't choose a carve out PBM. You're restricted, but the data's revealed. That's an ASO arrangement. There's a chance for carve outs if you get big enough. And then, so what we say is you have to cross the river from the Buca territory of control, I'd say of carrier control, cross the river, self-funding, and now you're in company control. Now the company controls everything. But guess what? You have to find stop loss for your risk. Well, there's 100 companies willing to buy your risk. You have to find a PBM. Well, good luck. There's 100 companies that'll be your drug manager. You have to have a TPA to pay all your claims. Okay, guess what? There's 100 of those. So everyone's like, oh, great, I've got a lot of options. And then there's about 100 point solutions. There's more than 100, but let's just say for the sake of argument, there's 100 doing a diabetes program or imaging or cancer or addiction or nutrition, 100. Well, guess what? That's like, I don't know what that is. That's
400.
Hundreds of thousands, millions of permutations, right?
Yeah.
And so therein lies the problem we started with. Once you get freedom and you cross over to self-funding, you get all your data, you get to rent a network, so you can get a Cigna or Aetna or whatever logo on your card to get access everywhere, but you're in control of your program. You get to build it, and people just fall apart because it's really hard. It's really hard to choose the best PBM given our employees and their locations and the cancer drugs we're on. So that's what we do is we sort through hundreds of vendors in each silo and put together the best architect, the best plan, and then manage it. And so that's the unique thing we do, because that's what the market needed, right? Is once these people were leaving Buca land, they'd land in self-funded and they'd go, oh my gosh, I found a good PBM, but I don't like my TPA and I don't like this. And I've got people with diabetes, but they're not getting glucose monitors or test strips. And we're spending a ton of money on, I'm just going to go back to fully insured. And we were like, whoa.
No. Yeah. That's interesting. That's kind of like, it's really, it's interesting how you see these trends happen across industries,
Yeah.
because this is not only a problem in the healthcare world, this is also a problem just like in the internet in general. Like if
Sure.
you, for example, if you look at even 10 years ago, how many like social media influencers did you have? Or how many physical
Right.
therapists or doctors or whoever did you really have creating content online?
Right.
You know, it was probably a small amount compared
Sure.
to now. I mean, basic, at least from my feed, like it's like every therapist I know is creating content, you know.
Yeah.
So
Right.
it's like it's all, or like, you know, I have a podcast, and guess what? Like hundreds of thousands or more people have podcasts. You know, you can't
Right.
listen to all of them, and
Well,
so
I likened it to the stock market, which this was blew my mind years ago. That there's X amount of stocks. I don't even know what it was back then. Let's say 5,000, and there were 7,000 mutual funds. And I'm like, how does that happen? They all have various mixtures or permutations of the 5,000 stocks or whatever it was. There were more
yeah,
mutual funds than, and I'm sure now with ETFs and everything else, it's probably even worse. I think that's kind of true in what you're saying is, uh, it's almost be careful what you wish for. Um, the problem is, or that like Google solved was when the internet grew, used to know the 10 sites you wanted to go to. Now
yeah,
there's a billion sites. You needed a
yeah,
crawler to
yeah,
organize it all. It's kind of like where we are in healthcare. If you go, if you truly want a customized plan, which everyone would say, well, if it's managed by somebody, that's what I want. I want my person with ALS to get the best ALS treatment, not to just wander into a hospital and get seen by somebody who has one person they've seen with ALS in their career,
right,
which happens. If you have that one person that's got a troubled pregnancy or a special autoimmune disease, I mean, there's a lot of outliers out there, and there are point solutions that are the best in the world available, but they're not in Blue Cross or United or Cigna or Aetna. They're only available most of the time to self-funded groups. Um, Somebody needs to stitch them together. Somebody needs to be a place where you can get records exchanged and reporting and hold vendors accountable. And the big picture here, Nate, is that years ago, everyone in this business managed to what is a pool, a risk pool. So think about it. Blue Cross is right down the street from me here in North Carolina. They have a giant risk pool. It's a public pool kind of. Think about it.
yeah,
People jump in. You can get individuals. You can get businesses. They have single people and 100,000 employee health systems in there, I bet. Right? It's a big pool. Lots of risk in the pool. But the law of large numbers is there. So if somebody joins with cancer, it doesn't upset the whole pool, right?
right,
It just takes the quality level down a little bit for the performance. And then people said, this risk pools aren't very efficient. I want a private pool. I want my own private pool. Captives are a good example of that, where you said, hey, everyone who swims in our pool has to do these 5 things. They have to have nurse navigators and high quality care and zero deductibles and a better drug plan. And that weeded out all these people, but there's still 100, and boy, they perform really well, right? Private pool, everyone's clean in the pool, everyone's doing what they're supposed to. Sure, they still get cancers, they still get ALS, they still get expensive hemophiliacs, but overall the performance of the pool is way better than the public pool.
sure,
Now what's happening is what we're talking about is moving to people. So you move from pool to plans, like group health plans, where everyone talks about how's that 500 employee company, the plan performing? How's the plan? How's the plan? Now we're moving to people. What I mean by that is, this individual health plan, you're still participating in a plan and it still sits in a pool, but the emphasis is on Nate saying, Nate, here's the drugs you took this year. Here's your age and your what you've shared with us, because you don't have to share. But if you share your 23andMe or you've answered a mental health assessment and you're grieving for a loss, or whatever it might take, or you're concerned about your A1C or your HDLs or your heart rate or blood pressure or whatever your concerns may be. An individual health plan is proactive. So you might red flag something and say, "Hey, I'm really concerned about the levels of this, and what do I do about it?" Instead of waiting for something to happen and being reactive. And so the tools are out there to connect, and the transparency rules, part of which are under CAA, to say you have a right to your electronic health records, right? And that's come even before CAA, but you have a right to that. It was just hard to implement. Well, now it's getting easier. And so there's people that can crawl the Cerner and Epic systems and bring back to you a PDF of Nate's health records. Well, it doesn't make a whole lot of sense yet. So what we're trying to do with some of our partners is clean that up and add goals and make it understandable. So you could get an annual health report, probably near your birthday, maybe not on your birthday, but probably near your birthday, to say, here's some, you set your goals, make it interactive, quid pro quo, what are your goals for next year? Your goals this year were to meditate more. Have you made time for that? Your goals were to walk, after dinner, or your goals were to limit carbs, or whatever it may be. And would you want to do a blood test to get some accurate data? Maybe not every year, but maybe every other year. Things like that. And it's tailor-made to the privacy that the individual wants to share, quid pro quo, to get back. The more you share, the more you get back. But if you don't feel comfortable, don't complete it. Your records are still there and they belong to you. It's just that heretofore no one sent them to you.
Sure.
And so I think that's the movement we're seeing, right? Is towards the individual.
Yeah, and I think that's ultimately, like, that's the people. That's like, it's you and me. It's like our mom and dad. It's our kids. Like, it's people at the end of the day. Like, it's interesting coming from like working literally with one-on-one with patients to now I'm discussing like, oh, it's 500 lives or five. It's like, it sounds weird talking about it in that way because like at the end of the day, it is people. It's
well, you're good to say that. Yeah, they're your patients. To an insurance underwriter, they're belly buttons, which sounds even more bizarre, right? It's like, what? I could never wrap my mind around that. They're like, how many belly buttons? I was like, belly buttons?
Is that really?
That just means total lives. Say you have employees. Let's say you have 200 employees, but they have 100 dependents. So you have 200 employees. They're the ones who pay for the health insurance.
Right.
And then you have 100 dependents. So you have 300 belly buttons on the plan is the terminology.
I am don't know how I feel about that.
That's a little hard. It's a little hard to get used to. You have to hear it 100 times before it washes over you. But
I'm like, I think with that, I'm a big proponent of using language that is like person centered. Yeah. And I think it makes a difference in how we approach things too. And so I understand the terminology of lives and belly buttons and all of that, but still, like, coming from just a healthcare provider perspective, I just think if we maybe even adopted just, oh yeah, it's 600 people. Like it doesn't dehumanize it. Like, it almost like dehumanizes it by calling it certain things. And it's just interesting that we do that as people in this space.
Yeah, no, there's a lot when you get down to the actuarial, as I like to separate, there's health care and there's health insurance. And a lot of people in our industry use those words interchangeably, and it's to their own detriment and to everyone's detriment because, as we kind of half jokingly say, no one mixes up their life with their life insurance or their car with their auto insurance. Why do you mix up your health with your health insurance? Like, why do people use those interchangeably?
Right.
And you can't lower the price of health insurance until you lower the price you pay for health care. Those two are, that's where they meet, right? And so, what we're all about is saying, okay, if you're spending $10,000 per employee per year on health insurance, that means you're probably spending about $8,000 on health care, and the rest is admin and fixed fees and things. Let's look at the $8,000 per employee per year in variable costs. That's the price you're paying for drugs and medical services, procedures, um, and say, where are we spending too much there? Because if we can lower those costs by 25%, which we do on average, then you're lowering the overall price by 20% because you're not changing what you pay for telehealth or the broker fee or fixed
Sure.
costs. You can only impact variable costs. But heretofore, everyone in this industry talked about cost containment. That was the, if I had a nickel for every time I heard that word, we wouldn't be here. I'd be on a sailboat somewhere. But cost containment doesn't work. Why? Because all you're saying right from the start is you're conceding, you're giving up the territory. You're saying we just want to hold the costs where they are. Well, that never works. You're overpaying for drugs. Don't accept that and say, not another nickel, Sopranos. We're not paying another. No, go ahead and pay less for those drugs. Don't do cost containment, do cost reduction. Don't pay $75,000 for a brand new doctor. By the way, the new doctors are Release the Hounds happens on July 1st, where they all get their new knives and go out into the surgery centers while all the veteran doctors are at the beach or the mountains or whatever. And so God forbid the people who get their first their knee replaced on July 1st, they're often seeing a doctor who's done one knee, yours. So you can pay less for better care. You just have to know how to navigate there, and don't pay full freight. Don't be the only person or the last person paying full freight for healthcare. But the first filter needs to be quality, right? If you're buying drugs and you're switching somebody to a formulary equivalent, you have to talk to the doctor. Our doctors and doctors of pharmacy, PharmDs, talk to their doctors and say to the physician, hey, Nate's doctor, we'd like to switch Nate to this formulary equivalent, not the branded drug you recommended that's $1,000 a month cost him. And they're like, invariably, they're like, I didn't know it was so expensive. Oh, yeah, yeah, yeah. Can we switch him to this generic? It'll actually be free for him. Then the plan will pay 100%, and the price is only $150 a month, but the plan will pay. So it'll be free to Nate. And they're like, oh, sure, I wish I would have known that. That's what we always hear. And then the switch is done. You just saved, $1,000 plus, every time. And the plan is glad to pay that because they're paying less. Their share of the generic is less than their share of the branded drug.
Sure.
It's just the pharmacist gets paid for the dispensing fee. So everyone's a winner except your old PBM, right? And so you have to turn over every rock in order to save the money for these plans. They're just nobody's going to do it with cost containment. You have to be proactive and actually reduce costs for the people in the plan to make a difference. But that's the delta between status quo and hero is on average 25 to 30% gross, and then you give it incentives back to your people, and you end up netting about 20 to 25% savings.
Yeah, I mean that's huge.
And I'm not the only one doing this, obviously.
Sure.
There's other people doing it. We're just doing it a little differently, where we're investing heavily on the technology side to stack and integrate with those point solutions so we have proof of performance for all the vendors.
Sure. Sure. Yeah, and I think there's a drastic need, as you said, for an aggregator. I think we were in the time of production and
Yeah.
creating, and now we have enough. We have enough selection. We have enough to choose from, and like you kind of said, we have this. We're like, especially in self-funded plans, like there's this ultimate freedom that comes with it, but with freedom can come also the nth degree of freedom is anarchy. so
Yeah.
so you
Yeah.
can have like this crazy, you're just like you have no idea what's going on. So that's also a problem. So I think we're to your point, we're definitely moving into this era of aggregation and consolidation, and not like the normal consolidation of like Google and Apple and Facebook acquiring all these different companies, but an aggregation that's a little bit more democratized, where you have a platform but it's housing all of these separate companies, but it all integrates together. And that to
Yeah.
me is actually really nice because it's, if you have one company that tries to do everything, like what company does that well?
Right. No,
No,
yeah,
no
no,
company does that well. Like Louis Vuitton is not selling in Target, and Target's
right,
not trying to sell like a Louis Vuitton bag, right? You
right.
can't have both in one
Yeah, no,
company.
I think,
So
yeah, I think you're right. In the as data becomes more available, quality and cost, or say value filters to the individuals through research apps, transparency, sunshine rules, all these various things, people are getting more data, right? So now they know it's kind of the Yelp review of their doctor or their surgeon. It might not be deadly accurate, it might be bedside manner. I care more about bedside manner for a pediatrician than I do a brain surgeon, right? Personally,
correct.
I don't care if my brain surgeon's an asshole, well, as long as he's the top guy, right?
Right.
But you don't want a jerk for a pediatrician, right? Come on, you know. So there's very, quality metrics is the talk of the is the topic of discussion at a lot of our conferences and things like that. But all this is getting filtered out to the plans and to the people like never before. And so I think you're going to start seeing, to your point, more demand for this. Like, what are, taking action, right? Like, why don't we have, this available on our plan? Well, and we're getting that feedback from HR professionals who are like, man, our people are asking about this now. I'm like, wow, really? How are they hearing about this? Whatever it may be. I mean, last year it was Ozempic, but
Right.
whatever it may be, there's going to be more fodder in those cannons every day as the people get more information. So if you have a BUCA plan and it's bundled, you can't do anything to it. You're kind of insulated. You're sort of protected by, if you're HR or CFO, by saying, no, we can't do anything. We can't do that. We're with the big guys. The danger is once you're unbundled and you've got the freedom to add and subtract vendors. One of the downside risks could be you with the freedom comes responsibility. Like, what are you going to do to avoid anarchy? What are you going to do? So we have to step in and say, here are the rules. Here's the SPD. The plan language matters. And we can't not follow the SPD. So if the plan says that you don't have to pay any copay, coinsurance, or deductible if you choose high quality care, oh, okay, great. Well, who's determining what's high quality?
Right.
Oh, it's the nurse. Okay, well, how's the nurse determining that? So we have to follow the logic of the law, and the SPD is the document that rules the plan. And so it all comes back to, what are you putting in your SPD? So that's super important to these folks that are deciding out there. Maybe it's time for us to get more freedom. We'd love to save 20-25%. We'd love to have zero deductible. All of our plans have zero deductibles. Now there's still a $3, $4, or $5,000 deductible in the plan language, but that only applies to the people who go to the hospital when they, and didn't call their nurse to go to a better doctor nearby. So if you insist on paying $80,000 for a knee in a hospital, then you pay the regular old freight rate, and it might be $5,000 deductible, $10,000 max out of pocket. Well, that knee in the hospital is going to cost you a lot of money. Not to mention,
Sure.
the hospital is typically 10 times dirtier than the ambulatory surgery center for infection and COVID and everything else. And the best surgeons have left the hospitals by and large and gone, because they can own the surgery center. They can't own a piece of the hospital. We explain this to the employees, and sometimes they're like, no, I really want to go to the hospital. I love the brand. And we're like, wow, okay. Can we at least steer you to the best doctor in the hospital, who's not even as good as the top 10 in the surgery center? But if you choose high quality, you pay zero. If you choose low quality, you pay regular old freight rates.
Sure. So I'm curious what you think on this. It's kind of a high level question. So let's say that, because you were saying that, like, 5, 10%, 15% of the employers who have VUCA plans, they're just tired of their premiums going up by, double digits every year for the past couple of years.
Yeah.
And they're starting to choose more self-funding. And so we're kind of in this era of that, right? What are the BUCA plans doing to resist that change? Because whenever I see a shift where they're going to lose market share, I mean, these are collectively $1 trillion, it's $1 trillion behemoth, right? Between all of them, I think
Yeah.
it's probably a trillion. Maybe it's not quite there, but it's close.
Yeah. Right.
What are they doing to fight back?
There's all sorts of tricks. So one thing is retention bonuses that we see more and more frequently, where the BUCA will offer, the broker's getting say $20 to $30 per employee per month in a fee. That's a lot of money.
Yeah.
And on top of that, they'll also get money on the life insurance, dental, vision, critical illness, worksite stuff too.
So the broker who is controlling the plan design is incentivized highly by the BUCA plans to keep
sure.
the employer on
Yeah, the ski
plans that are not
trips.
in the best interest of the employer.
Yeah, there's famous flyers that have circulated of, showing people in the Bahamas with the Blues, United, Cigna, Aetnas, or going on ski trips, or getting $100,000 bonus if you move them from self-funded back to fully insured. They'll pay you $100,000. I've seen that. So there's all sorts of, and they call it a marketing fee because it's going to take a lot of marketing to get them to switch. And so there's all sorts of hush money and slush money available from PBMs. Just last week, Prime Therapeutics announced, and I think it was in the Nebraska Blue Cross plan, that they were going to give an incentive to brokers who were smart of extra money if you move them over to the more expensive Prime Therapeutics PBM. Now, why would anyone do that? They would only do it for the money. It is clearly more expensive for the humans and the employer to move them from a proactive, transparent PBM to Prime Therapeutics. The only reason is cash bonuses. And so we see all sorts of tricks that the BUCAs, like I said before, they could teach the Sopranos a thing or two about how to run a bit, how to keep the corner clean, And so there's all sorts of ways they can reimburse the broker and the agency. So they can say to the agency, hey, you've hit all your targets. You've given us 100 clients. Thank you very much. And then the owner of the agency might say, wait a minute. I know 3 or 4 of our best brokers are thinking about leaving the BUCA and going to a self-funded plan. That'll drop us below 100. What are we risking? Oh, a $500,000 agency bonus. Oh, well, we've got to put the end, we got to stop that, And so there's all sorts of ways to be paid, right? And I certainly don't know of all of them, but it's as dirty as you might imagine it could be.
So what are other than like the risk and the seemingly complex nature of switching to self-funding, what are the barriers that the decision makers are like let's say that, because self-funding is not for everybody, right? Like there are like companies that just wouldn't have the administrative capacity to handle it, or are just way too small, so they couldn't really address the risk properly.
That's true.
Lots of different reasons, and I'm sure there are many more than that. But what for a company that is appropriate, who like could definitely handle it, what are some of the top reasons why the decision makers, not the broker, are not making that decision to move into self-funded?
That's a great question, Nate. I think the main thing we'd see is, I go back to inertia. They're like, as much as it stinks to be with fill in the blank, a BUCA, they're all relatively the same. They don't like change, and the HR people, if they have a say, are often not even invited to the big meetings with the CEO and CFO. HR is not treated as a C-suite job in a lot of companies. It's treated as more of a, on a lower level.
Hmm.
and they're often overworked. And what the HR people will come back and tell us is, hey, I think your plan is way better. It clearly helps our employees, and I love our people, but it's more work for me. And guess what? I can't. I'm not getting paid any extra to do this, and I just feel like it might be too much work, so I'm going to pass. And so we were like,
Might be
wow.
too much work. What do they? So I always like when somebody says that, I like to get to the root of it. So what do they
Yeah,
mean by too much work?
I think, anytime there's changing the ID card, changing the customer service, changing the PBM, everything's changing. The people doing the Zooms, the enrollment changes, the legal changes. There's a lot of paperwork with a health plan, right? And so that the HR knows that they're going to that's going to sit on their desk. And the CEO and CFO might be like, oh my gosh, we love the savings. We love the better care, lower cost, more control. Let's switch. And then they leave the meeting. And then it's all on the HR's desk. And HR is like, oh my gosh, I wish I could hit the easy button and stay with blue, or whatever.
So
Um,
how? So then my next question is, okay, how do we make this easy for you?
Yeah, I think the first thing you have to do if you're constructing these proactive plans is mirror the plan language as much as you can. So you say HR often has a lot of pride in what's in the plan. Sometimes not, but a lot of times they do. And say, we're not going to throw your plan, the baby out with the bathwater. We're going to take your plan and mirror it. We might have a few tweaks, but there won't be that many. And they're like, okay, check box. We like that. Okay. And then we have a big compliance component. Make sure your fiduciary risks are mitigated and the lawyers look at it, ERISA attorneys, and check. Okay, great. Okay, now how much are you paying per month? And they might say, we're paying 100,000 or 500,000, whatever it is, for our fully insured plan. Okay, what if we kept that number? Would that be good? And they're like, wait a minute, I thought we were going to have to pay every claim as it came in, like band-aids and brain surgeries, we'd be writing checks off. We're like, no, 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 no. You just fund a monthly, you take the annual fee, let's say it's 1.2 million for my math skills. And then you say, okay, if you keep your employee base the same, it's going to be $100,000 per month, level funded, right? Any any risk above that is paid for by the carrier. You're not responsible. And they're like, wait a minute, that's a lot like our current plan. Yeah, we mimic your current plan.
Hmm.
But at the end of the year, if you've only spent 800,000, you've got 400,000 in cash in your account, not Chuck E. Cheese coins or anything else, but cash. And so you don't have to fund January, February, March, and April. Your CEO likes that. You don't even have to fund the health plan. It's got reserves. And so the savings are real and they're in cash. And so that's the big difference. So and here's the next question I'll ask because it was what people are thinking. We always get this. What if there's $1 million claim in the second month? Like that's what I always say. It's never in the
Yeah.
first month. It's always like,
Right. It's always
what if
second month.
$1 million transplant in the second month? And I'm like, aha. So you paid 100,000 in the first month and you had, let's say, $50,000 worth of expenses. So you have $50,000 in reserve. And then you got $1 million claim in the second month. You've only paid in 100,000. So now you have 150 in reserve, but you have $1 million claim. So you're responsible for what? And they're like, the $1 million? I'm like, no, you're responsible for the 150,000. That's it. You can't spend more than your reserve. In other words, the insurance company, the underwriter pays 850 and you pay the next about 100 and you had 50 in reserve. So you pay 150. And that's how it works. And so
Yeah.
then the next month you pay 100, the next month you pay 100. You have no risk above your specific deductible. And so that's the way it works. And people, the light goes on and they're like, well, that's even better than what we're currently doing. And we're like,
So
okay,
yeah.
you're welcome. So in other words, some people like to pay as they go and we let them do that. But oftentimes, especially in the plans that are say under 500, they like to hit the easy button and say, what's our monthly rate? It's $300,000 or 400 or 500 or 100, whatever it is. Okay, that's what you budget that's what you fund. And then the TPA sweeps that out, pays all your bills, and you have no responsibility above your specific deductible.
Sure.
And so that's an easy way to do it. The bigger you get, the more flexible you want to be. you don't like having a lot of money in the reserve because it's not working for you. But if you're a smaller company, you like the safety of and simplicity of a monthly payment, typically.
Sure. So when you have you ever had somebody you come to with what you just said to me about the just really you're protected because you have your stop loss there, right? Have you ever had somebody come back and be like, "Well, yeah, but what's like what's the objection that then comes up
Well,
after
yeah,
that?"
I typically start with like health insurance has a lot of acronyms and has a lot of names and that don't really match up to what they do. But stop loss is aptly named. It's the only thing that does it says exactly what it is. It stops your losses. I tell people just think about it. You set your own deductible. So we help. You can't be below 25,000, and we coach people. We run some Monte Carlo and risk scenarios and stuff like that, and say, hey, a company your size with your cash flow, your risk, your employee base should be 50,000 or 100,000 in spec, and here's the numbers, and then we get it underwritten to that, and we say, oh, well, here's your monthly payment, and then 9 out of 10 times they say that's great, but in what you're mentioning is that 1 out of 10 who raises their hand and says, what about this? Like, why this? And those are typically the companies that either A, don't want to fund to 100, the full, what we say, max funding, fund all their risk up front. They'll say, how frequent do we hit max funding? And we'll say, well, like 1 out of every 10 years or something. And they're like, okay, well, then I don't want to fund to that. I like to fund to less than that. I want to fund to 110% of my expected, or less than the max.
Mm-hmm.
And that's good and bad. You're still responsible for the full risk, but you don't necessarily have to fund it all. And it gets a little complicated. Some people like to make things that are simple complicated. And I can appreciate that.
Yeah.
I'm typically the other way around, but I understand where they're coming
I
from.
mean, because this sounds like it sounds like a no-brainer.
Yeah, and that's okay. I'd say that's the main reason why we run into problems is people will say literally to us, this is too good to be true. Because if this were true, why doesn't Blue, United, Cigna, Aetna do it? And I'm like, well, because they're making enormous margins on status quo. Like,
Right.
they're
Why
like,
would why would they change it if they're making enormous amounts of money? In fact, if they did it this way, they would make less money.
there's no way they're going to do that. And I just saw on my whiteboard, I was doing a little video. It's because of MLR, it's medical loss ratio. During ACA or Obamacare passage,
The 85 or 80/20 rule.
yeah, it's 80/20 on the small groups and 85/15 on the large groups over 50. So any 99% of the employers in America, they're making a guaranteed 15%. So they're incentivized. And in fact, their fiduciary rules are not to help Nate, but to help their shareholders make more money. And the way they do that is to get your premiums up so that they're guaranteed 15%. And so,
Yeah,
and when they're all doing it, you don't have any options. So,
yeah,
that's the thing with the merry-go-round. If you stay on there, they're all doing the same MLR trick. And so they're all profiting from it. So you have to leave the merry-go-round in order to find a horse that's not racing after that 15% add-on and those, inflated profits on top of paid claims, and that's the hard part. So I would say the hardest part in our business right now is it's too good to be true, or I don't qualify this year. That's a tough one because I just got a new high cost fill in the blank, like a leukemia just hit our plan, and the underwriters are like, we don't know how much that's going to cost, but you only have 55 employees, and it could be $800,000. It's just too variable, and your plan is too small to account for that.
sure.
And so it's really hard when a group is really interested. They're strategically looking at it. They're thinking long term. They've done all the right stuff, and they just have a variable on their plan that is not getting them. It's not a good time. That's tough.
Sure. Sure.
That's a tough call. I'd say that's number two. And And then number three is the reactionaries, and those are the folks that only call us because they got a 40% or a 30%, or as they joke in healthcare, or in insurance, I should say, when your house is on fire, it's not a good time to shop for house insurance. It's you got a 40% increase. There's a reason for that. And you're being reactionary, and it's going to be really hard to find you a good quote. Sometimes we pull a rabbit out of a hat and there's a mistake, but oftentimes it's because you have several problems that haven't been addressed, and you have to stay in the bucca land for another year until you get cleaned up, and then you can come over and take more financial responsibility. But
Sure.
yeah.
The last thing I wanted to touch on was, because I like to it's easy for us to talk about the problems all day long. And it's important, I think, to understand the problems very intricately so that we can come up with solutions that actually work.
Right.
And we kind of been going back and forth between those two, but what would you say if you could wave a magic wand? What would the perfect healthcare system look like?
Gosh,
I know it's a big question.
no one's ever given me that, and in fact, one of our marketing pieces is a quote from our first client who said, when we laid out all of the costs and how we only saved him like 5% on certain things, but 30% on others, but it all added up. He said, "Oh, it's not magic, it's math." Okay, great. And I was like, "Did you think it was magic?" And he's like, "I didn't know, but thank you for showing me it's math." And so if I had a magic wand, I'd still want to get back to math. But I would say, that the transparency rules would have dire consequences for those that don't. I don't want more laws. We have enough laws. But there are laws in place to say, like, the hospitals have to publish all of their pricing. Well, guess what? The penalty for not doing it was $300 a day. You're talking about hospitals. I'm situated here between Duke and UNC.
$300 a day.
$300 is like closing a window in the CFO's office. It was, and those two actually reported, but a lot of them didn't. So make the penalties meaningful. I would say, I believe in merit, and that we have to take care of our sickest and least able, number one. But number two, if somebody's able to make decisions and they choose wisely, they should pay less. I mean, I think there should be some incentive for being in shape and staying that way, and things like that. Now, there should be no penalty for getting cancer, things out of your control. But I believe if I had the magic wand, I would want to have the incentives and the penalties more closely aligned to reward people for choosing higher quality doctors, higher quality facilities, those kinds of things, because a lot of people go to the nearest clinic and it's dirty and the doctors aren't very good. And then they're shocked they got a new disease, or they, and I'm like, this data needs to be more available so people make wiser decisions. And I think that's part of what we talked about earlier, that as we move from pools to plans to people in our information or our focus, that having that annual health plan, even if it's a half a page or 2 pages, I really like that idea, because everyone likes, that's how we think, right? Is goals and annual stuff. And I think if I could wave the magic wand, it would involve incentives and penalties, but giving people the data to make wise decisions. I think that's the most important thing.
So to kind of summarize that, transparency in pricing that actually has penalties if you don't publish your prices. Yeah. And what that will be able to do is actually incentivize people to shop for higher quality physicians and other healthcare providers, as well as facilities. And if you have that transparency and people can make those choices, then that can lead to just overall a better system that has actually higher quality, better accessibility, and lower costs overall.
Absolutely. That's a more efficient operating system for healthcare. And I think, I like the market. I think the market can correct itself, but only in a transparent, incentivized way with real data.
Sure.
If we went to a single payer and the government was in control, I don't think that the quality would improve. I don't think the pricing would be as transparent. I just don't think that there'd be as much incentive for doctors to work harder and better and be more transparent. I want them to be rewarded more, you know. And so
Sure.
that's my take. But well, we covered a lot of ground.
We did. Thank you for being on today and just sharing your knowledge. That was a great conversation. I'm sure. I know we could have an even longer one, but
Yeah.
we'll have to save that for next time.
Yeah, Nate, I really appreciate it. Thanks to you and all you're doing out there. It's been a pleasure getting to know you, and I really look forward to continuing the conversation. And yeah, please knock on the door if we can be helpful in any way, getting you more information. That's what we do. So
Awesome. And then one last thing, how can people find you and get in touch with you?
Yeah, so we're at herohealthplans.com, and you got to spell it all out because we found out Hero Health is actually a pill dispenser for the elderly. So it's like so herohealthplans.com.
Cool.
And we'll be presenting at the Health Rosetta Conference in Chicago in August, and we just finished the Validation Institute Conference in DC. So we like to train brokers and C-suites on how to be better buyers and sellers of health plans. So if you're a broker out there and you want help on architecting plans, we'd like to help you. If you're a C-suite executive and you'd like to find out how to buy plans better, we do guides for you and brochures and surveys and things like that. So we're trying to make this market more efficient. So that's what we do. But thanks for asking.
Yeah, awesome. Cool, Patrick. I'll catch you later.
All right. Bye-bye.
Bye.